So I'm going to go from looking forward and what capacity can be in the future and how we get there to the fact that we do live in the here and now. And I had the pleasure of speaking to my two panelists this morning. I'm going to introduce Cassie Sutton Coates, who's the Clinical Operations Manager at Open Door Health here in Providence, and Emily Adams, Nurse Practitioner for Open Door Health. They're a fairly new medical services provider in the Providence area, and I will say that I'm kind of blown away and incredibly impressed by how quickly they have had to pivot in this period of COVID-19. You've had to move from inpatient care and operating your clinic with physical contact to going to a telemedicine scenario just about overnight. That has just been amazing, so that you can continue to reach out and connect and care for your patient community. But what I'd like to do is, Emily, why don't we start with you? If you would tell us a little bit about the organization, your patient care practice, and how you have converted that into a telemedicine operation at this point in time.
Yeah, thank you. Yeah, so Open Door Health is an LGBTQ clinic. We opened in March, so brand new. We're just in Providence and just very excited to be here with you all today. I think we opened one day after the first case in Rhode Island for COVID. So it's definitely been a big time of change for us. I think by the end of March, we realized that we were not going to be able to continue to see patients in clinic for the safety of our population, but we knew that there's still such a need for healthcare and specifically for marginalized populations like the LGBTQ community. And so we, I think, in the course of one weekend, figured out how we're going to be providing our services online. So we use Zoom, with the HIPAA compliant version. And basically, I think me, Cassie, and our front desk staff, Alfie just tested out a bunch of different ways to get people in and respect privacy and make this as fluid as possible. So on Zoom, patients get a link to their EMR system and through their portal and get brought into like a waiting room. And then Alfie brings them into the main session, checks them in, then puts them in a breakout room where the provider meets them. And we get to do the full encounter via video conference. For patients who can't access video, we can do an audio call where the provider just calls them and can do all the onboarding over the phone. And, you know, we're doing vital signs and physical exams over the video and, you know, checking with people. And so it's been pretty wild and it's worked pretty well so far. Definitely some drawbacks in terms of, you know, there's definitely acute illnesses where it'd be great to have hands on our patients. But we're also seeing that, you know, patients who have unstable housing are having problems accessing. And then even when we're trying to, you know, understand where our community is and what they need, we're feeling, you know, it's hard to even hear from those people since everything is, you know, a Google sheet or Google form or, you know, monkey survey or something like that. So, you know, there is definitely a huge barrier to getting people to use these services, especially when they're very needed.
Is there an advantage though to this experience that you're having now?
Yeah, it's been great. I think one piece is that a lot of community members in the LGBTQ people have problems accessing services from people who are trained. Specifically, my area is gender affirming care, which is covering hormones, helping patients navigate legal and surgical affirmation. And so finding providers who are trained in this and competent can be difficult. So we're hoping that we can reach more people. Additionally, we have 2 doctors who specialize in HIV care and Hep C, which is a service that, you know, we want to additionally be spreading and making sure is easily accessible. A lot of the care that we give also requires more follow-up and frequent check-ins. And so I think that this can decrease the number of in-office visits and really improve care and outcomes for patients, since they won't need to be thinking about missing work or finding child or elder care or transportation, or even a fear of stigmatization when they go into clinics. So far patients have really appreciated that we've remained open and that it's been pretty easy to access these services.
You raised an interesting point, and that is one of privacy. So I'm going to switch over to Cassie. when we were just touching on some of these topics this morning, first of all, congratulations on swinging your operations over to a virtual existence, because I know that that was a big lift for everyone. But you had spoken pretty eloquently on the HIPAA implications of going to a telemedicine scenario. I wonder if you could share that a bit with the attendees here today.
Sure. So at the, the impetus for our switch to telemedicine really was this current pandemic crisis that we're in. I think it was always something that we had thought about in the back of our mind as we were really putting together the clinical infrastructure and IT infrastructure for Open Door Health, but it was never something that we anticipated launching within 2 weeks of opening. So when we were faced with this, it was, how do we actually put this into practice? And when you think about what goes into telemedicine, it's like at its core, it's really simple. It's like you basically need like internet access, you need a camera, you need a device that can access the internet. But that like is a really reductionist view. And I think most of our, internally, we had all of the like software access and the hardware access and the internet access, even for our providers to move completely to offsite work. Like everyone had that offsite at their homes, but thinking about the privacy is completely different. It's such a, in many ways, it's kind of an ethereal concept. But at the beginning of this crisis, like the HIPAA laws were suspended to allow for telemedicine to actually occur. And it was geared to make it easier for physicians and mental health providers to actually meet with their patients at a time where maybe it's dangerous to actually go on site. So that was something that was helpful for us in thinking about, okay, this could be possible. But simultaneously, those HIPAA laws are really important and they're really valuable. And the LGBTQ community is one that has experienced so much trauma and so much stigma in so many different and varied elements that it was really important to us to try to figure out how we could maintain the privacy so that they could continue to get reliable and really affirming care in a private setting. So, we spoke to folks on our community advisory board and we got a lot of really positive feedback about the potential for telemedicine, with the caveat being, how do you keep the privacy, even with these HIPAA, sort of like the lift for HIPAA restrictions. So we considered using the Google Meet services, and we considered using FaceTime and, a whole bunch of Skype, I think was one of them. And we settled on Zoom, and that of course was right around the time where Zoom was experiencing some of their own like privacy issues, and all of that was coming to light. And some of our CAB members reached out to us saying, why are you using Zoom? There's huge issues with Zoom. And that was, right in this time where we were also figuring out, okay, well, Zoom has Zoom for healthcare. How do we get that? So we did end up going with the HIPAA compliant version of Zoom. We were lucky enough to be able to do that, which, it's end-to-end encryption on both sides. And we kind of eschewed the lift on the restrictions for HIPAA because that privacy just, it's not something that can be just lifted that easily, I think, for a community that has experienced this kind of trauma. So I'm really pleased with the fact that we were able to get it to work. I think there's different barriers that exist with Zoom, so it's not perfect. And I think we're, considering how to make this sustainable more long-term. Maybe Zoom is the answer, and maybe it's not. So we're kind of continuing to think about what it might look like moving forward in terms of sustainability, but always with an eye towards the privacy and respect for our patients.
Sure. So you have something that works today, but Emily, I'm going to go back to you. What's it like doing the patient intake process over the phone? I mean, as somebody who probably, I'm sure, prefers hands-on and in-person conversation, what is that experience like trying to gain trust for your patients and have them gain confidence in the process. Tell us a little bit about that.
Yeah, it's been good. We have an amazing patient population. They've been incredibly patient. I've definitely been dropped off calls at times, or, ask people to repeat things, which can disrupt flow. And I think that's a big piece. Additionally, I find it can be harder to kind of consult with my peers since we're not in the same building anymore. So we've been navigating that. I do think that's like a lot, easier to follow up with people. No one has to come out of work. So, we're having lower no-shows and, more flexibility with time since we're at a lower volume. And so far we've gotten very positive feedback. I think all of our patients and us as well are excited to meet in person, hopefully sometime this summer. But it's been going really well. Additionally, we're partnered with Eastside Clinical Labs, so we are able to send our patients to get labs same day when it's clinically necessary. So, we are trying to be flexible during this time as well.
So where do you see this going? Telemedicine, where Emily, for the clinic with your medical director, your executive director, where do you see this going in the future? How much do you think you might incorporate telemedicine in once we get past our COVID-19 point in time?
Yeah, I think, so some of it also is based on insurance companies and reimbursement models. I think telemedicine is crucial in terms of increasing access, especially for populations that, we know, these health disparities are ongoing and we're not doing anything, and we're seeing them even in the response to COVID, right? Mortality, morbidity rates are very different depending on where you live and your race and ethnicity. And so I think thinking specifically about HIV care, gender affirming care, these services that are, require more expertise, that I hope that we can consult with other providers and provide like on-site support. I hope we can increase and pull more people in just by being able to continue to offer these services after the pandemic. And so this has always been something we wanted to incorporate. And I think behavioral health, which is not necessarily my expertise, will be huge. And I think, people being able to access therapists and psychiatrists and psychologists more easily will be transformative.
So one of the things that we talked about is that you have the folks that you can connect with today, but you know that there's a group out there that you're not connecting with. So what are your plans for the future there? They don't have access, or they're just not trusting of the technologies. They're just not savvy to the technology and how to use it. What are your plans going forward?
Yeah, it's a little tough. I think one area is older adults, and thinking about how many of them are very willing to try and get on this technology. But, as soon as you kind of meet barriers, right now it's very limited in how people can access help. And so thinking about, we've been able to get on the phone and walk it through for people. But in the future, when there can be more of a mix of on-site clinical and telemedicine, integrating that in a way where we can be teaching people how to access these services, and thinking about how, helping them set up a Gmail account or helping them learn how to use Zoom can really improve outcomes outside of healthcare as well. It can change the way they're engaging with news sources and, dentistry and healthcare and education. And so, thinking about how we can integrate that. I'm afraid I don't have all the answers in terms of how to reach out to,
Sure.
While we're all still at home, and we definitely be open if people have ideas. I think especially for patients who are having pretty drastic connectivity issues.
So to those connectivity issues, Cassie, I'm going to bounce this back over to you. You were sharing with me the challenges that you have with a disconnected population that is not even aware of the email addresses that they might have, and some of the circumstances they may have with data plan limitations.
Mm-hmm. Yeah, so I was taking a look. We use our patient portal. So we were lucky enough, before making the switch, to have a really heavy investment in our IT infrastructure. Everything was cloud-based or internet-based for us. It was really easy for us to make that switch. We relied pretty heavily on obviously really heavily on an electronic medical record system. And it has an integrated patient portal, as pretty much all of them do these days. But I was taking a look at our patient uptake of the patient portal, and it's really high, But when I looked at the patients who weren't using the patient portal, you can tell that they're the patients who are living in congregate living settings, who might be homeless or have unstable housing, patients with lower incomes. So there's a lot of these like intersecting factors that really impact a person's ability to access the internet just to log into their health portal, let alone access, telemedicine services. We've encountered a couple of patients who, don't have email addresses, who therefore can't access the patient portal. Other patients who are interested in getting healthcare using telemedicine, but say they're relying on their cell phone because, they have a cell phone and it has a camera on it. Because they can't go to a library or they don't have access to a computer with a camera. But there was one patient who was pacing outside of a homeless shelter for their visit. And I remember, I wasn't with the patient, but sort of was troubleshooting on the back end and heard about the story and the troubles on the back end. And, their data usage, there's only so much data that people have, especially when they are living in these situations and when they do have lower incomes and might not be able to pay a lot of money for wireless or cell phone coverage or anything. And the signal was dropping in and out, and there was, constant like connection and reconnection for this patient. And, they were remarkably patient. But it's still a frustrating experience, I think, for both the patients and the providers to be in that situation. And it can be a challenging thing to navigate. And I think, to Emily's point about us working with really remarkable patients, they're really incredible. They are really patient. I think that patient in particular even like helped us like work through it. And I think they eventually transitioned to a phone call for the remainder of the visit when they were done with some of the parts that had to be done on video. But so much of it is having to be adaptive, especially to patients who don't have the access that is otherwise required for really intentional like video encounters.
So I have a question here asking about HIPAA compliance in some of the digital payment apps such as Venmo. Have you encountered any issues or had any concerns along those lines now that you have to work so remotely?
We haven't. So we process payments directly through our medical record system. We collect credit card payments over the phone or over, the Zoom. They read their card info to us. The sessions are not recorded. It's complete, that part is HIPAA compliant at least, and then it's processed through a HIPAA compliant backend. But I do think that does pose an interesting question. So far, we haven't had any issues collecting those payments. A lot of the folks who don't have access to like credit cards and whatnot actually haven't had to pay copays up front. So we haven't encountered those kinds of challenges, but we do have patients, like when we were seeing patients in person, we had patients who needed to pay in cash, who wanted to pay in cash, and we're not doing that right now. And we can't accept payments with Venmo or Square or whatever else. So I do think that poses interesting questions about, if someone does need to pay in cash and can use Venmo, like what are these other services doing to help create that, encryption and extra security that would be required.
Thank you. Emily, just back to you. What are your patients enjoying about this, and what are they not? I mean, obviously the connectivity issues, they're heralded for their patients and dealing with them. But have you had any other comments or interactions with your patients that where they're not 100% satisfied with this temporary new world?
Yeah, I think kind of the major areas are times when, we end up having to refer to another site because they do need like a physical exam or more testing. So, I've had patients with bacterial pneumonia or, asthma exacerbations or, GI illness. And, that's something that we always want to be providing and be the first person there on, in person. So there are some limitations in medicine and what we can do over the phone. So I think, then having 2 appointments is really frustrating. However, I do think, we're able to offer same day appointments and really follow up closely. Additionally, there's a lot of mental health crisis going on right now. And so I've been checking with some patients on a weekly basis because, these situations are, we have people at home who, are not able to be out to their family, whether about their gender or sexual identity, and really the risk we're putting at people at when they're in those situations. And so being able to follow up closely and just continuing to monitor has been good.
That's good to hear. Now, you're affiliated with the university system in Brown's Department of Public Health. So you're collecting a lot of data and experiential and anecdotal information about dealing with COVID-19, a pandemic in this situation, and the uses of telemedicine. Do you see an opportunity working with Brown going forward to improve these types of services, or I'm just asking you to perhaps unfairly speculate on where that might lead?
No, I think it's great.
Absolutely.
We published a paper like a week or 2 ago about what Open Door Health and did with telemedicine and kind of our model. I'm currently working on a paper speaking to the feasibility of providing gender affirming care through telemedicine, even out, in the pandemic and outside of the pandemic. So we're really hoping to capitalize on what's going on.
And I think, we're hoping to do some more robust, quality improvement and evaluations of the telemedicine programs, as we think about building this more sustainably. We want to hear from our patients, and we want to hear from the communities that we're working with, what's working, how can we do it better, and put that, really put that into practice. Our medical director and our executive director, their background is in research, clinical and community-based research. And that's, that data is really important because you have to build up sort of that background understanding to be able to move forward and make changes. And that's, part of where Open Door Health came from, and where we kind of hope to give back is that local wealth of knowledge and understanding for the local community. Because that's really important and something that we really haven't had.
I also, I do see 2 comments from someone in the chat. One was earlier about doxy.me. And I think there's a lot of other options for HIPAA compliant video services. Part of our choice for Zoom was based on affordability for such a small clinic. Many of these services aim at clinics that are groups of over 100 providers, and we are 2 full-time providers and 1 part-time provider. So some of our choices have been also about what's feasible for us as a clinic. And then many of our patients, in terms of families declining to take video calls, many of our patients in the LGBTQ community have fallen out of care for a very long time. We've seen some adults who haven't seen a doctor in 30 years. And so for them, I think there can be a lot of opportunity and relief in coming to a clinic that's focused on providing affirming care and using language that's inclusive, doing testing that's appropriate. And so I think that's been a major piece. But we're also allowing people to say they have a preference. It's okay not to want to do a Zoom call, and it's okay to book further out. We're mostly want to prioritize when people want to do video calls or when something's urgent. And I think it's reasonable to say that telemedicine is only a piece of it.
Well, I applaud you both and your colleagues for being able to pivot your model in the blink of an eye, it would seem, in these times. I've been very impressed. And Cassie and Emily, I thank you both for your time today.